Hello, good day to everyone. The topic that I'm going to discuss for this session is more about on the diagnosis of TB disease. This includes all presumptive TB, whether DS or DR, whether children, adult, elderly, regardless of age, sex, including the high-risk groups. So what are the objectives for this session? At the end of the session, the participants should be able to, number one, apply the NTP policies and procedures for the diagnosis of TB disease. So we have policies and procedures in the diagnosis of TB disease. So hopefully that after this training, you're going to apply all those policies and procedures related to the diagnosis of TB disease. Request the appropriate diagnostic tests using the Form 2A, laboratory requests and result form, and the laboratory specimen receiving form. This is the usual forms that we've been using all these years, although it has been revised during the revision of the MOP, but this is still the form that we will still be using when requesting for diagnostic tests. This is the Form 2A laboratory request and result form. And of course, the laboratory specimen receiving form. Number 3, you will learn how to interpret result of diagnostic tests and determine the appropriate action following the diagnostic algorithm. So later in this presentation, I'm going to show to you the new diagnostic algorithm. During the 5th edition of the MOP, we also have this algorithm, but now this is already updated. And I think this is more comprehensive and more manageable. Number 4, we also learn to decide on clinical diagnosis of adult and pediatric patients based on sound evidence. So as far as the clinical diagnosis is concerned, in this session, you will learn to decide especially on the clinical aspect of diagnosis for both adult and of course our pediatric patients. Number 5, define and differentiate the TB disease classifications. So this is based on the bacteriologic status, anatomic site, treatment history, and drug susceptibility test. Moving on, we have some definition of terms. As always, when we have our revision of the Manual of Procedures for MTP, there are definition of terms which we need to fully understand. So number 1 definition is, what is an active TB disease? Simply, it is a presumptive TB that is either bacteriologically confirmed or clinically diagnosed by the attending physician. So when you say bacteriologically confirmed, this pertains to the diagnosis in the laboratory. And when we say clinically diagnosed, it is something to do with the decision of the attending physician to diagnose active TB disease. Number 2, we have pulmonary TB. So pulmonary TB usually involves the lung parenchyma. So this is something of abnormalities in the lungs. And this also includes not only pulmonary, but when we have both patients with pulmonary and extrapulmonary TB, they will still be classified as PTB, pulmonary TB. I think we have not changed this policy even in the previous MOP. Number 3, extrapulmonary TB or EPTB. So we know very well what is extrapulmonary TB. These are tuberculosis involving organs other than the lungs. Like, for example, the larynx, the pleura, the lymph nodes, the abdomen, genital urinary tract, skin, joints, bones, meninges, etc. Moving on to our definition of terms, how about BCTB or bacteriologically confirmed TB? This is a biological specimen, either sputum or non-sputum sample, is positive for TB by smear microscopy, culture, or rapid diagnostic test. Example are the expert MTB RIB, the line probe assay, or the LPA for TB, including TB lump. So when a biological specimen comes to the laboratory, whether sputum or non-sputum, when you say non-sputum, it is related to extrapulmonary specimen. And they turn out to be positive by smear microscopy, either by culture or rapid diagnostic tests, such as the GeneXpert. So they are labeled as bacteriologically confirmed TB. Now, number 5, as usual, we have this kind of definition even in the old MOP. Number 5, this is a clinically diagnosed TB, CDTB. Now, the criterion for bacteriological confirmation is not fulfilled. That means to say, as far as BCTB is concerned, they are not confirmed because their samples turns out to be negative. Now, it is also a diagnosis being made by the attending physicians. Okay, so based on clinical findings, X-ray abnormalities, suggestive histology, and other biochemistry or imaging tests. So let's move now to the next. So another definition is new. So far, there is no changes at all when we say new in the 6th edition of the revised MOP. When we say new, the patient have never had treatment for TB, or if they had, it should be less than 1 month. So once again, as a reminder, preventive treatment is not considered as previous TB treatment. This refers to our, previously we call it IPT, or preventive treatment regimen is not considered as previous TB treatment. Number 7, previously treated for TB. So these are TB patients who have at least received 1 month or more of anti-TB drugs in the past. So whether they have received 1 month or more than 1 month, for as long it is more than 1 month, so that means to say the patient is defined as previously treated for TB. Now, number 8, high risk for MDR-TB. So what is the definition? There are 3 points here, which is covered for high risk for MDR-TB. Who are high risk for MDR-TB, by the way? So this includes the previously ever treated for TB. These are the retreatment cases. And the next point is new TB cases that are contacts of confirmed DR-TB cases. So if it's a new TB cases, then they are contacts of the confirmed DR-TB. So therefore, they have the high risk for multi-drug resistant TB. And the last point is can be considered for high risk for MDR-TB, the non-converter among patients on DSTB regimens. So any patients who did not convert their treatment, especially on the second, the fourth, and the sixth, the fifth, and the sixth months, so they are can be suspect for MDR or high risk for MDR-TB. Number 9, what is RR-TB? Rifampicin resistant TB. So this is resistance to rifampicin detected using phenotypic or genotypic methods, such as a gene expert, which can detect rifampicin resistant with or without resistance to other anti-TB drugs. So we usually have our gene expert, and one of its results will be MTB detected, rifampicin resistant detected. So this is an example of how we define rifampicin resistant TB or RR-TB. Now, what is turnaround time? How do we measure the turnaround time? So this is the time from the collection of first sputum sample to initiation of treatment for TB. This is also referred to as program TAT or turnaround time. And what is the desired turnaround time? This is at least 5 working days. Once again, I'd like to make it clear that as far as turnaround time, program TAT is concerned, it is a time from the collection of first sputum sample to initiation of treatment for TB. So that is 5 working days. Now another definition of terms in terms of disease classification by drug susceptibility testing. I know you are familiar with these terms. We have the so-called monoresistant TB. When we say mono, from the word mono means only one. So this is resistance to one first-line anti-TB drug. Now another definition is polyresistant TB. So this is resistance to more than one first-line anti-TB drug. No? But other than both isoniazid and rifampicin. So that means to say, when you say polyresistant TB, both isoniazid and rifampicin is not involved here, because once they are involved, they are already multi-drug resistant. But we are talking about polyresistant. So that means to say more than one first-line anti-TB drug. It can be pyrazinamide or ethambutol, but never isoniazid and rifampicin for them to be defined as polyresistant TB. I hope you get this. Now, rifampicin resistant TB, any resistance to rifampicin detected using phenotypic or genotypic methods with or without resistance to other anti-TB drugs. So this is already our RR-TB as previously discussed. While the multi-drug resistant TB, resistance to at least both isoniazid and rifampicin. The extensively drug-resistant TB or XDR-TB, this is resistance to any fluoroquinolone and to at least one of the 3 second-line injectable drugs, in addition to multi-drug resistance. Actually, this is just a review because this is still included in the previous MOP. Now let's go to the policies. Take note of the red font. That means to say, whenever you see a red font, it means to say that there are changes in these policies, or some policies are changed. No, so we will be going to the policies one by one. Number one, a rapid diagnostic test. And this is the new term now, rapid diagnostic test, or RDT, such as expert MTB-RIF tests, will now be considered as a primary diagnostic tool for pulmonary TB in both adults and children. So nowadays, we will be utilizing expert MTB-RIF tests. This is now considered as the primary diagnostic test for all presumptive TB. Now, for presumptive EPTB cases, the body fluid or biopsy samples that are appropriate. Okay, so for EPTB cases, we use the body fluid or biopsy samples that are appropriate in order to test for TB using our primary diagnostic tool. Now we have DSSM, direct sputum smear microscopy, or TB-LAMP, shall now be the alternative diagnostic test that, if expert, is not yet accessible or feasible. As you notice, we have already expanded our RTDL, the Rapid TB Diagnostic Laboratory. For this year, we will be going to have an additional of 16 more laboratory and another 2, so that makes 18 RTDL. But then it is not yet sufficient enough to cover all our population. So there will still be some facilities will still be using the alternative diagnostic tests, especially for the GIDA areas and the far-flung municipalities. So DSSM will still be considered as alternative diagnostic tests in the absence of expert, if it is not yet accessible or feasible. So all presumptive TB who are high risk for MDR TB shall be referred for expert MTB-RIF testing using our sputum transport system. But for those areas with presumptive TB and who happen to be high risk for multi-drug resistant TB, you still have to refer them to the expert MTB-RIF laboratory, because we cannot determine if they're MDR TB unless we will be testing using MTB-RIF assay test. So we have our SG striders who are going to transport the specimen from the referring facility to the Rapid TB Diagnostic Laboratory. Number 3, direct sputum smear microscopy, DSSM, or the so-called bright field or fluorescence microscopy, as the alternative diagnostic tool. As already mentioned, DSSM, whether it is bright field or fluorescence, will now become the alternative diagnostic tool in the program. So another thing is the TB-LAMP, loop-mediated isothermal amplifications for the diagnosis of pulmonary TB. So this TB-LAMP can be utilized to process large sample loads, especially when we will be conducting an active case finding activities. So more sample can be loaded in order to test So we will be utilizing this TB lamp instead. But this is not recommendable for diagnosis for children, person living with HIV, and MDR-TB risk groups. Okay? As we continue, number 4, policies. If bacteriologic testing is negative or not available or accessible, physicians shall decide on clinical diagnosis based on best clinical judgment. When was the last time we heard about best clinical judgment? Isn't it during our 5th edition of the Manual of Procedures? Yes, we heard about best clinical judgment. So in the absence of laboratory testing, or if it is not accessible, so physician still will give, they have the option whether to treat or not to treat their patient. But this is still based on their clinical judgment. Number 5, tuberculin skin test or TST, an adjuvant where there is no doubt to make clinical diagnosis of TB in children. Okay, so either 5-TU or 2-TU strand are regarded as similar in producing induration indicative of TB infection. Okay, but once again, I want to remind everyone that only trained health workers can do the testing and reading for the tuberculin skin test. So there has been no changes at all in terms of the reading for the tuberculin skin test. A positive tuberculin skin test has an induration of at least 10 millimeter, regardless of BCG vaccination. Now, for immunocompromised children, especially example, the severely malnourished, at least 5 mm is already considered positive. Number 7, health facilities with TB services. We encourage that all facilities, health facilities with who renders TB services must establish their own in-house TB diagnostic laboratory, whether expert NTB reef, if not, at least you have direct sputum smear microscopy or the TB lamp. If it is not possible, then access to officially linked NTB accredited TB diagnostic laboratory can also use, no? So because they are really time that just like the expansion of the GeneXpert, we cannot really expand all of the RHU or convert all the TB microscopy laboratory at one time only. So we're doing it gradually because of the reason for still we have to see the factors behind all this distribution of the expert, and it's not just setting out the expert and performing the expert. We also need to consider, especially our donors, no? The one who is giving us the free machines, including the cartridges and other materials that is being needed. Number 8, all laboratories providing TB diagnostic tests, whether public or private, shall participate in the quality assurance or QA system of the NPP. So there has been no changes at all because we will still continue our quality assurance system, whether you are performing GeneXpert, DSSM, or TB lamp, there will still be quality assurance. Number 9, a TB Medical Advisory Committee. This is the TB MAC, no? I think you're already familiar with the word TB-MAC, shall be established at least one per region. So their role is very important because they are here to provide the clinical expertise and guidance in the diagnosis of clinically drug-resistant TB, and most especially for the management of difficult TB and drug-resistant TB cases. Um, there will really be time that we will be going to encounter cases that is very difficult to manage. Even at the RHU level or the hospital level, it's really hard to manage that kind of cases. And this is also very much possible. So we need a medical advisory committee such as the TB-MAC. In every region, we need their expertise and we need their decision on the management of especially the clinically diagnosed drug-resistant TB and even those with difficult TB cases. Now let's go now to the procedures. So presumptive TB is identified. After identification, we diagnose them through bacteriologic confirmation. So collection of the necessary specimen for testing, and then we perform the test, expert DSSN or TB-LAMP, and then we make the diagnosis based on the results. Now, as far as the collection and transport of sputum, you prepare the sputum cup or conical tube, and of course, along with it, the laboratory request form. Then after that, after the preparation, you're now going to instruct the patient to expectorate one sputum sample. After the collection, you still need to check the quantity of sputum. If the examination is for DSSM, at least 3 to 5 millimeters in volume. If it is for expert or LAMP, there should be more than 1 ml. Again, you check the quality of sputum. By the way, it's not the quality. First, you have to check the quantity. Then after the quantity, you also check the quality of sputum. It should be good quality sputum specimen. And we know very well what is a good quality sputum specimen. We go to that later. Then we label the body of the cup or tube with name and the test. And if there's a need for the second collection, second sample, so it can be collected 1 hour apart, or it can also be collected early morning at the house of our patient. So we seal the cup and the tube and pack securely and transport with laboratory request form. Okay? So in sealing the cup and the tube and in packing the specimen, see to it, we will be implementing the triple packaging system. Then afterward, the DSSM specimens can be fixed into smears. It cannot be sent immediately. So we have our informal laboratory workers who can do the smearing preparation instead of transporting the specimen to the laboratory. They can do the smear and transport the smears to the nearest laboratory. And lastly, EPTB samples must also submit sputum specimen for testing. Okay, it's not just sputum specimen. but even including also the extrapulmonary TB samples, they should also submit sputum specimen for testing. You may never know. They have both, they might have both pulmonary and at the same time extrapulmonary TB. Moving along, we have our collection and transport of specimen. When you say specimen quality, this is considered to be the optimal quality of our sample, which is purulent and mucoid. Now for DSSM, as already mentioned, at least 3 to 5 ml of a good sputum sample. And as much as possible, mucus from the nose and throat, these are not considered as good specimens. So we should not collect specimen coming from the nose and throat because these are not considered as good specimens. That's why before we collect, we instruct our patients on the proper technique in order we can get a quality sputum sample that is coming deep within the lungs, not coming from the throat, neither it should come from the nose. I think this is very clear. Now let's move on. For expert, at least more than 1 millimeter. So when you say more than 1, it can be 2, 3, up to 4 millimeters. But there are also samples that are not ideal, but we can accept. What are they? Salivary specimen. Although this is an ideal sample for expert, but because we considered expert more sensitive than the DSSM, so we can accept salivary specimen for as long as, once again, we always emphasize instruction was being given prior to collection. Okay, even though sample with blood streak, for as long as it is not a massive hemoptysis, which is not acceptable, blood streak in the sputum can be considered for expert. So for extrapulmonary specimen for expert MTB assays, we have the specimen type and the corresponding volume needed. But before anything else, let me emphasize again that blood, urine, and stool are currently not acceptable specimen for expert MTB reef testing. So once again, blood, urine, and stool, these are not acceptable specimen for expert MTB reef assay. So respiratory specimen other than sputum, we have the tracheal aspirate, endotracheal aspirate, bronchial washing, bronchial alveolar lavage, and fluid, and nasopharyngeal aspirate. So what will be the volume? At least from 1 ml to 4 ml. Now there are also non-respiratory specimens, such as the gastric aspirate. We also have one with a volume of 1 to 4 ml. The CSF. So for our RTDL, you can actually test using GeneXpert with a specimen of our CSF, or the cerebrospinal fluid. At least how much fluid do we need from the cerebrospinal? At least 0.5 to 4 millimeter. Okay. Now, the last two specimen types, which I'm going to discuss to you. So this includes other fluid aspirates and body fluids. Example, peritoneal, synovial fluids. Another one is the tissues and fine needle aspirate biopsy specimen. Although this specimen, is acceptable for gene expert tests, but then this specimen, this kind of specimen, type of specimen, this can only be done specifically to a designated rapid TB diagnostic laboratory with certified biosafety cabinet, such as in TB culture laboratories. So you will not be able, those laboratories with no biosafety cabinet cannot perform the test for this type of specimen. Only the laboratory with biosafety cabinet. Like for example, the Zamboanga City Medical Center. It's a TB culture laboratories which is equipped with certified BSC, a biosafety cabinet. Actually, CCMC is a biosafety level 2 laboratory. This is also the reason they were qualified to do COVID testing, because it requires a biosafety level 2 laboratory. So just for a review, in sputum collection, we need to accomplish the following forms. These are recording forms. Number 1, Form 2A, the NTP laboratory request and result form. Number 2, the TB laboratory specimen form. So we were going to discuss these two forms as a review. Okay? See to it that you're going to fill out completely the laboratory request form. You have the name of the requesting facility. Then you also need to fill out the date of request, the facility contact information, the requesting physician, the name of patient. It should be written the first name first, or the family name, which is all capitalized, followed by the last name should be capitalized, followed by the first name. Then you also indicate the age, check if it is male or female. Then please do not forget to write the full address of our patient, including the patient's contact number. Most of the people nowadays has already their own cellular phone. So basically, we can get their contact number, and it should be placed here under the patient's contact number, okay? Now, the reason for examination, you have three choices here. We have for diagnosis, baseline, follow-up. So you just check one, diagnosis. If it is for diagnosis, you also have to identify the history of treatment. If it is new or retreatment. In this sample, it is for retreatment. Now, if it is for retreatment, then we also need to identify the registration group. Is it new, relapse, treatment after loss to follow-up, or TALF, or PTOU? So check only one, okay? And of course, if it is for follow-up, then you just have to indicate the TB case number, okay? The specimen type, you check only once, sputum. If it is not sputum specimen, then you have to check other, then you specify example CSF. Then you also need to check, is it a repeat collection, yes or no? So in this sample, you just have to check no. Okay, so that means to say it is a new collection, first time collection. Then on this table, we have the number of specimen, 1, the data collection, we also indicate the data collection. And then if it is for expert, DST or LPA, you have to indicate if your patient is presumptive DSTB or presumptive DRTB. In this case, it is a presumptive DRTB because the patient is a retreatment case and the patient's registration group falls under treatment after loss to follow-up. Then after filling out, then you have also to indicate what are the tests you are requesting. So you just have to check whether DSSM, MTB, expert MTB-RIF, culture, DST, or LPA. In this sample, it is for experts, we check for expert. As we move on to our sample of our filling out of our laboratory request form. So after you have done filling out the form, you have to indicate your name, prepared by your complete name and then with signature, and then your position. So this is the first half of the form. The last half of the form is located below. And this portion, as we all know, it should be filled out by, sorry, let's go back. Should be filled out by the medical technologists, the microscopists, or the expert technician. So they're going to indicate their laboratory serial number. And then they also need to indicate what was the date they received the specimen and what was the date they examined the specimen. Okay, so below is already the result of our tests. So we have divided into 2 columns. The first column is for the smear microscopy, and the second column is intended for expert MTB-RIF. As you notice, the visual appearance is for expert is here, and then you just have to indicate whether the appearance is salivary, mucoid, or mucopurulent. In this sample, this is mucopurulent. And then the medical technologists will going to indicate the reading or the result of your MTB-RIF, and it should be right completely. No, it should be right completely, just like in this case, MTB detected, rifampicin resistance detected. So RR detected. If it is not MTB not detected, they also have to write. So you notice that if it is a red ink, that means to say it's positive. No? Whether MTB detected only with rifampicin resistant undetected, or with rifampicin resistant detected, or MTB detected rifampicin undeterminate. So you have to, this portion should be written in red ink, okay? Okay, so much for this. So we have the signature of the medtech or the expert technician. So they have to write the complete name with their signature. And then they also need to indicate the release of their result, the result, when did they release the result, okay? So I think that's all. So this MTP lab request result form, if you're familiar with this is coming from our ITs. When you encode also in the ITs, it looks somewhat the same with our hard copy of our NTP lab request form. But I think this is much easier because all the things that needed to be filled out is already here when you encode it in ITs. including, so you just have
It's 4 o'clock.
You just have to include all the details of your patient, and then the portion for the medical technologies, which is the result portion, will be filled out by them. Now, this is the second form that we'll be using, especially when we transport specimen to our laboratory. This is the form that is called TB Laboratory Specimen Receiving Form. So from the collection unit to the laboratory. So you have to, again, following the order of the name of our patient, the last name should be capitalized, followed by the first name. Then you also indicate what test. So you just put GX. Date collected, also put the date of collection. And then below, you also have to write endorsed by the one who is referring, and then the date, okay? And then do not also forget who received your specimen, okay? So basically when you refer it to the laboratory, it will always be the medical technologies or the expert technician who are going to receive. So that means to say the name should appear here, including their signature and also the date. Okay, so let's continue. But before we proceed, always remember to accomplish this form in duplicates. Now let's talk about the expert MTB-RIF test. This is sensitive and fully automated rapid test that detects MTB and rifampicin resistance. This is the machine that enable us to detect MTB and rifampicin resistance in less than 2 hours. And what is good in this kind of method, it needs minimum laboratory expertise. So we know that for training on GeneXpert MTB-RIF assay, it's only 3 days, okay? As compared to direct sputum smear microscopy, we need at least more or less 5 days. Because in sputum smear microscopy, there are a lot of procedures, not only procedures, but also you need to develop your skills, not only in the collection specimen, but also in smearing, particularly in staining, and also in reading. But unlike with the GeneXpert machine, we have a very minimal laboratory procedure. Everything is being done, is being processed by the machine. Once you load the specimen into the GeneXpert machine, that's it. You will not going to do anything anymore, but you just have to wait. And the result will just come out. Okay, and as far as the biosafety requirements, this is similar to sputum smear microscopy. So you don't need to establish another laboratory for GeneXpert. The same laboratory you have when you are still a TML or TB microscopy laboratory, the requirements of biosafety is just the same. Okay? So for as long as there is a good ventilation in the laboratory, so that will not be a problem anymore. You don't need to install or you don't need to purchase a biosafety cabinet. Of course, for COVID testing, there's really a need to have biosafety cabinet, because we know that what we are testing here is a very contagious organism. It's a virus. So that is the reason why it should only be tested with biosafety laboratory level 2. So for the gene expert, when you test for TB, specimen only. So as long as you have a good ventilation in the laboratory, same with your sputum microscopy, you have your tabletops where to place your machine, so that's already okay. So these are the results and interpretation for our gene expert result. So we have the notation T written in red ink. It means to say T represent MTB detected, rifampicin resistant not detected. So still, this is still positive, because this is MTB was detected, but this is only a DSTB, or drug susceptible TB. It is not an MDR, because rifampicin resistance were not detected. Now, for RRTB, when you say RRTB, it is MTB detected, rifampicin resistance detected. So this is MDR. Now, TI, still positive for TB, but the rifampicin resistance is indeterminate. This is the thing that twisted my tongue a while ago. Indeterminate. So that means to say, it is a sure positive for MTB, but rifampicin resistance cannot be determined yet. So it needs to be retested. And the second test will be final. Okay, so what is N? So we are now on the black ink. That means to say it is negative, or MTB, the interpretation is MTB not detected. I represent invalid, no result, or error. And the actual computer system of Gene Expert, it will really show to you if it is invalid, no result, or error. But these three things, when we interpret it in the result form, it is big capital I. Okay? So it can either be invalid, it can either be no result, it can either be an error. Now let's go to the DSSM. So we know that we have two methods for direct sputum smear microscopy: the bright field and the fluorescence. The bright field using the Ziehl-Neelsen method. This is something to do with the staining method being utilized. Where the fluorescence, we are also using the fluorescent reagent for the specific test. Now, conventional test serves as a basis for diagnosis of TB. Now, this can also be used to monitor progress of patients with TB while on anti-TB treatment. Okay, so we cannot use Gene Expert to monitor the progress of our patients. So what I'm referring here is the sputum follow-up. We still need to do the SSM, either to bright field or fluorescence. That's why that is why we cannot let go of our conventional method. Although we have already the new method for in the diagnosis of TB, but DSSM will still remain, because we still be using DSSM to monitor the progress of our patients. And also, the DSSM also confirmed cure at the end of treatment in drug-sensitive TB case. Again, GeneXpert is only for diagnosis. For follow-up examination, we still need to use our conventional tests, our direct sputum smear microscopy. Okay, so we have this slide on the DSSM interpretation and results. I think I don't need to linger here anymore because most of you are already familiar with this, especially the wide field microscopy. You are familiar with the result 0, no AFB seen, plus n, the actual number, plus 1 to plus 9, the 1 plus, the 2 plus, and the 3 plus. So the bright field microscopy is utilizing, as far as the microscope objective is concerned, we are using an OL immersion objective. No? This is high power objective. Wherein for fluorescent microscopy, 2 magnification can be used. One is the low power magnification or low power objective, and the other one is the high power objective. So it will now depend on the power of the objective that you'll be using. Originally, we'll be using the low power first. Then after we have identified the bacilli, then we will be shifting to the high power objective. And you will see that the result really varies, no? So when you use the low power, more of the AFB can be seen at one field because it is broad and the coverage of the low power covers a lot of field in one focusing, wherein the high power objective, because you will be focusing only on portion of the field, so you will notice that lesser of the AAB can be detected, can be quantified here as compared to the low power objective. Okay, I know the medtechs who are watching right now has this idea. Okay, so let's continue. So how about the LAMP? LAMP represent the loop-mediated isothermal amplification for TB. Now, this can be used as a replacement for sputum smear. No? If you don't want to do smearing anymore, then use the LAMP for diagnosis of pulmonary TB in adults with signs and symptoms. Okay. So all specimen positive for this result, the only disadvantage is that once you have positive LAMP, there's still a need to refer your specimen to be tested for expert MTB reef. Why? To identify resistance. Because only GeneXpert has the capacity in identifying resistant strains, particularly for rifampicin. While the LAMP can be a good method in identifying larger number of specimens for MTB, but it cannot detect resistance. So still, when you have a positive LAMP, so you still have to subject the specimen positive for GeneXpert in order to identify resistance. Okay? So this is the results and interpretation for our LAMP. It's only positive and negative. Once there are fluorescence, as you can look below, there are it fluoresce. So that means to say it's positive. If there is no fluorescence, these are negative. Okay, so very easy to identify. You don't need to quantify. It's a matter of positive or negative. Hopefully, in the next years or in the coming days or future, I mean, some in the laboratory can also have this kind of TB diagnosis methods. Now, the decision on diagnosis based on laboratory results. Okay, if sputum or non-sputum specimens show MTB detected or positive result, we usually classify them as bacteriologically confirmed PTB or APTB. So MTB detected or positive result, we classify them as BCTB or bacteriologically confirmed TB. Now, if negative diagnostic tests are not done, okay, if the result of the test, the diagnosis is negative or was not done, we need to retrieve the chest X-ray result, or you do need or do chest X-ray if not yet done. Okay, chest X-ray PA view upright. So a course of broad spectrum antibiotics may be prescribed for these negative diagnostic tests. Now, if chest X-ray findings are suggestive of TB and are not resolved after antibiotic treatment, okay, so that's the time physician's best clinical judgment will come in and decide whether to treat or not to treat TB. But in this scenario, since the chest X-rays are suggestive of TB, and despite the administration of antibiotic treatment, so the attending patients will now use his best clinical judgment to decide and treat for active TB. Now, if the physician decides to treat as active TB, we can classify them as clinically diagnosed PTB. Okay, so this is specifically, it is a negative test for diagnostic test, but it is positive for chest X-ray. So again, this is as a guide for clinical diagnosis in adults. We have to understand and we need to be informed that GeneXpert will be positive in 92% of culture positive pulmonary TB and around more than 80% of DSSM negative pulmonary TB. So that means to say only a small proportion, that is 20-30% of patients with negative expert test is expected to be clinically diagnosed. So when we have the GeneXpert machine installed in our facility, we would expect that at least 80% of our patients are positive for pulmonary TB, and only around 20 to 30% will be diagnosed as clinically diagnosed TB. And we really like to see that more of the BC rather than the CD proportion. Okay? If no signs and symptoms, plus negative expert test. So this is very common, especially for those patients who has positive X-ray result and yet no signs and symptoms, and their expert test is negative. So what are we going to do here? Strongly consider doing surveillance with repeat chest X-ray instead of treating as TB. Okay, so this is another story when we say negative signs and symptoms, negative chest expert. So this is not unlike those patients with chest X-ray positive and with signs and symptoms. Definitely, physicians will really come in to execute their clinical judgment. But if your patient has no symptoms at all and has negative expert tests, so this is strongly considered by doing a surveillance with repeat chest X-ray instead of treating as TB. So for the clinical diagnosis in adults, these are the guide. Take caution with over and under diagnosis by chest X-ray. So we always have to, good chest X-ray result depends on the quality of chest X-ray image or film. If our X-ray film is not good, definitely we were going to have a not good image. So that will also, in a way, affect the reading of our chest X-ray. So inter or intra observer variation in chest reading also affects the so-called over and under diagnosis. Now, comparison of serial chest X-ray findings is useful to guide the diagnosis. Okay, so comparison of serial chest X-ray findings is even useful to guide the diagnosis. Referral to a specialist may be done if reasonably accessible or able to render a decision within 2 weeks. Now, if chest X-ray is normal or not suggestive of TB, you have to investigate for other morbidities or refer to a specialist. So most of the time we have this kind of scenario. The chest X-ray is normal, not even suggestive of TB, but then the patient complains of some symptoms of TB. So it really needs to investigate for other morbidities. Or the best, we have to refer to a specialist. Note, for PLHIV, if symptoms are present, TB is not immediately ruled out, even with a negative chest X-ray, okay? Now let's go to this algorithm. Please bear with me because we will be going to tackle this algorithm step by step. The first algorithm is the clinical diagnosis in children less than 15 years old. Okay, so we begin with presumptive TB with or without risk factors. Okay, so here comes our presumptive TB, less than 15 years old children. The next thing to do after identifying the child as a presumptive TB, you have to ask to expectorate sputum, especially to equal or more than 8 years old, or any child who can expectorate, or gastric lavage sample if available. So when you obtain the sample, you do the expert MTBR test. Okay? So when your MTB, your expert MTB test turns out to be positive, whether susceptible TB or MDR TB, then you have to start TB or DR TB treatment. Now, if the test turns out to be negative or the child cannot expectorate, that's the time you request for chest X-ray. Okay, now try to check the result of the chest X-ray. If it is strongly suggestive of TB with clinical signs and symptoms, you can now start the treatment for TB. Okay? So these are the chest X-ray findings strongly suggestive of PTB in children and adolescents. Okay, we have the source here. Okay, so for our pediatric patients less than 10 years old age, persistent fever, weight loss, cough, and irritability. So it might have the finding, the chest X-ray, right hilea, lymphadenopathy, okay, chronic pneumonia, miliary specimen, okay, all over. Then for the 10 to 18 years of age, persistent fever, adenomia, and expectoration, bloody sputum. It can be pulmonary cavitations or pleural effusion. Okay, pleural effusion. So going back to our algorithm, if the chest X-ray of the child is not suggestive of TB, but normal or uncertain, so what are we going to do? So you have to consider giving broad spectrum antibiotics. The most is for 1 week, if not given before. Then you follow up after 2 weeks. If clinically stable, if signs and symptoms persist, you have to determine if contact of a non-TB case may clinically diagnose as TB. No? If the child has contact of a non-TB case, the signs and symptoms still persist, then you can diagnose as clinically diagnosed TB. If not a contact, so you perform TST. Now, if TST is positive, may clinically diagnose as TB, okay? Now, if TST is negative or unavailable, but the signs and symptoms are unresolved, so that means to say the signs and symptoms persist, less likely to be TB, and referred to specialist center for further investigation and management. So there will be no problem if TST turns out to be positive. You can diagnose as clinically diagnosed as TB. The problem now lies when the TST is negative or the TST is not available, but the signs and symptoms unresolved. So it states here, less likely to be TB, and you have to refer to specialists for further investigation and management. Now, if referral to specialist center cannot be made, so there are also problems such as this. So decision to treat TB may be made by the treating physician. If clinically unstable, example, severe respiratory signs and symptoms or TB meningitis, or have risk factors for TB, okay? So if clinically stable and no other risk factors for TB, follow up after 2 to 4 weeks. Okay. So it will now depend now on the physician whether to treat or not. But of course, if you look at this portion, no, this phrase here, it says if clinically unstable. So physician may decide to treat the patient as TB. Now, if clinically stable and no other risk factors, we have to follow up after 2 to 4 weeks. Okay. Now, a while ago, I also presented to you the different readings of our chest X-ray. So chest X-ray findings strongly suggestive of TB in all children are markedly hilar and large lymph nodes, more than 2 cm in size or with or without opacification. Miliary moting, large pleural effusion, and apical opacification with cavitation. Now, number risk factors are less than 5 years old. Okay, HIV, severe malnutrition, measles, or immune suppressing drugs. For expert MTB result and treatment for RTB, you can refer to figure 7. Now, we will be discussing on the presumptive EPTB, okay? So, after identifying presumptive EPTB, you try to get the pus, tissue, or fluid samples for expert MTB test. And now, we subject it for MTB testing. So if the result turns out to be positive, then we start the treatment. If negative, if the samples for expert cannot be collected, consider or refer to specialist center for further investigations, okay? So we will only be up to here, okay? And we just follow if negative or cannot expectorate in the previous algorithm we have discussed. So if a presumptive TB is assessed as not TB, we have to evaluate for other differential diagnosis. So our assessment doesn't stop when we assess a patient as not TB, but we continue to evaluate for other differential diagnosis. If not symptomatic, you assure the patient and advise to follow up anytime if symptoms develop. That's the most we can do for this kind of patient. Now, all patients diagnosed with active TB, once again, as a reminder, we use Form 4, the TB treatment card, accomplished and registered in the TB register or in the ITs, regardless of whether initiated treatment or not. So you have to encode them in your respective records or ITs. For private physicians, mandatory notification using the prescribed forms is required by law. No, we already have the mandatory TB notification law. This is especially for our private physicians. They are required by law to use the prescribed forms. Now, decision on further testing based on expert MTB read. As already explained, our expert MTB read test has 4 major results, okay? It can be MTB positive with no RR. So this is susceptible TB. So you just have to treat with drug-susceptible TB regimens. If your result is NTB detected, rifampicin resistant not detected. Now, if you have NTB detected at the same time rifampicin resistant detected, you have to determine if your patient is a high risk for DRTB. You know already who are the high risk for DRTB. No? Example for this are for those with treatment patient, okay? For those having contact with MDR patient. It's a high risk group. Now, once you identify them as high risk for DRTB, immediately you can start with the standard regimen or individual treatment regimen after checking eligibilities. Now, there are also patients diagnosed for MTBR-TB, but when you assess their risk for MDR-TB, it's low because they are a new patient with no contact of MDR-TB, so they are considered as new. So we still have, we cannot immediately put them into treatment unless we're going to recollect or going to repeat the expert MTB RIP test and follow the second test result as what is being described here. No? Okay, just like the invalid error or indeterminate, there should be recollection and repeat expert MTB RIP test. And the second test result will be final. Now, what does it mean when we have the result no MTB detected? Definitely, in our mind, the patient has no TB. But there are also two considerations here that we need to understand. Okay, as far as the clinical findings is concerned, if still suspicious of TB, okay, if no chest X-ray before, you need to do chest X-ray. Now, this is for MTB not detected, but you have this suspicion that this patient might have TB. So what are you going to do? So you have to do chest X-ray. Or you can also, while waiting for the chest X-ray result, the antibiotic trial, and do any other investigation relevant to APTB. No? Baka we might never know that the patient has APTB instead of pulmonary TB. That's why his pulmonary specimen turns out negative when we do the gene expert testing. Or we can refer to TB-MAP for possible start anti-TB treatments. Now, if there is no clinical findings, if no suspicious but still have signs and symptoms, you have to investigate for other medical condition. Or we can start the latent TB infection treatment only for contacts of DCTB case or bacteriologically confirmed TB case. Okay. However, in PLHIB, wherein mortality from TB infection is high, there's no need to repeat the expert MTB RIP test. It will result in delay of treatment initiation. So we will only be, the treatment of our patient, PLHIB, will be based on the result of the initial test. We don't need to do the retest anymore or repeat the test anymore because of the explanation we have above. Because it is something to do with the high mortality for the TB co-infection. So, okay, I think this is clear. Now, classification of TB disease is based on bacteriological status of drug-resistant cases. I think this also been included in our previous MOP. So as a review, when we have the bacteriologically confirmed rifampicin-resistant TB or BCR-TB, the definition is positive for MTB using rapid diagnostic modalities such as the gene expert with resistance to rifampicins. So this is BCR-TB. So if patient have previously successful treatment, resistance should be from specimen collected after successful treatment. Now, another one is bacteriologically confirmed multi-drug resistant TB, BCMDR-TB. So positive for MTB complex with resistance to at least both isoniazid and rifampicin from an NTP-recognized laboratory. So a while ago, it is something to do with the GeneXpert. No? So we know that GeneXpert detects rifampicin resistance. That's why we call them DCRR-TB. But now, since this is MDR, so it involves both rifampicin and isoniazid, so therefore, we categorize them as bacteriologically confirmed multi-drug resistant TB. Third, bacteriologically confirmed extensively drug-resistant TB. Okay, so positive for MTB complex with resistance. No, it's just like the definition of extensive drug-resistant TB. We have this discussion previously during the first few slides we had. Okay, so again, resistance to fluoroquinolone and at least of the 3 second-line injectable drugs such as capreomycin, kanamycin, and amikacin, in addition to multi-drug resistance from an NTP-recognized laboratory. And then, fourthly, we have the clinically diagnosed multi-drug resistant TB. So this is the thing that we need to refer to the TB map because, as you notice, it's not that easy to diagnose, clinically diagnose multi-drug resistant TB. No? They are clinically diagnosed and yet they're MDR TB. So the definition here is at least one of the following. So your specimen tested in NTP recognized laboratory that is negative for MTB complex. Let me say they are negative bacteriologically, but with clinical deterioration, no, or radiographic findings consistent with active TB. Okay, it's more on clinical manifestation rather than bacteriological confirmation. Or specimen with other resistant pattern, no? So there's a resistant pattern like mono DRTB or poly DRTB, but not exactly MDR, okay? With clinical deterioration or radiographic finding consistent with active TB. Or laboratory diagnosis not done due to specific condition, but with clinical deterioration and radiographic finding consistent with active TB. Or diagnosis showing resistance to both isoniazid and rifampicin in a non-NTP recognized laboratory. Again, I'm twisting my tongue because I think we have a long topic. You know, I have discussed a long topic with you. Okay. And there has been no response, of course, of empiric antibiotics or asymptomatic medication. So as you can see, if you have any of the following, then we can categorize our patients as CD-MDR TB or clinically diagnosed multi-drug resistant TB. And who has been decided by the TB Medical Committee, TB MAC, to have TB disease requiring full course of second anti-TB chemotherapy, similar to BC-MDR TB. Okay? So that's it. That is for our clinically diagnosed MDR TB. Moving on with our few slide left for this topic. Number 5, we have the other DRTB. And under this, we have the mono-resistant TB. So as already mentioned, when you say mono-resistant TB, resistant to only one first-line anti-TB drug, except rifampicin, whether bacteriologically confirmed regardless of the date of collection with or without radiographic abnormalities, or clinically diagnosed, no? Such as a severe adverse drug reaction to anti-TB drugs except rifampicin, and who has been decided by the TB-MAC Consilium to have TB disease requiring course on mono-drug-resistant TB regimen. B, polydrug-resistant TB, a patient with resistance to more than one first-line anti-TB drug other than both isoniazid and rifampicin, whether BC, regardless of date of collection or without radiographic abnormalities, or clinically diagnosed severe adverse drug reaction to anti-TB drug except rifampicin. So similar to the mono drug resistant, except that this time it is more than one first-line TB drug. But the definition is just exactly the same with that of our mono drug resistant. And letter C, other drug resistant TB, we have the serious adverse drug reaction to rifampicin. So the definition is at least one of the following: positive for MTB complex, but no resistance to any anti-TB drugs. That means the patient is positive for MTB complex, but no resistance to any anti-TB. Or it could be negative for MTB complex, but has been decided, either by the physician or the TB-MAC to have TB disease and a serious adverse drug reaction to rifampicin, thereby requiring a full course of second-line anti-TB chemotherapy similar to BC-MDR-TB. So as a summary of the classification of TB disease based on BC status of drug-resistant cases, we have the BCRR, bacteriologically confirmed rifampicin resistance. We have the BCMDR, the BCXDR, the CDMDR, in which the TB complex is negative, no laboratory, or the DST is coming from other non-NPP accredited lab. It could be mono or poly, but treatment as MDR. Now for other diagnostic, we have the mono, BC, and CD. We have also the poly, BC, and CD. Then the serious adverse drug reaction to rifampicin. So I think I finished my discussion on the diagnosis for the revised Manual of Procedures 6th edition. So I'd like to thank you for giving your utmost attention for this topic. And after this topic, I think you have some exercises to do. So for you to be able to not only get familiar, but also get fully acquainted with all the policies that we have for diagnosis of TB. So I'd like to thank you for the time, and may you still continue to pursue with the rest of our MOP topics. Okay, so thank you so much, and good afternoon.